Yeah, I think this meeting was very rich in some of important either updates or new results. Those included our data, which were final data of KRD with transplant, of initial and post-transplant use for extended type of KRD, which produced results which are in our final conclusion superior to anything we historically have seen in myeloma. Just to highlight a few points, in patient population increased by about 30 to 40% high-risk patients. We achieved ultimately over 70% of patients stringent CR as best response. And at the end of treatment, the time when we made this analysis, 74% of patients have MRD negative status by next gene sequencing, which translated into what appears to be outstanding progression-free survival and overall survival at 3 years, exceeding for both over 90% and close to 90% for progression-free survival. Projecting again better than what we have seen. There were some toxicities in this study which to some extent seem to be at higher rate in a similar study design with shorter post-transplant KRD treatment in the French study reported by Dr. Seul from IFM. But what I caught from that particular presentation, that both studies showed almost identical rate of stringent CR at the end of 8 total cycles, 4 before and after, to some extent validating the approach, and which eventually translates in those outstanding results, which we need to, of course, wait a little bit longer from French study until we see whether their results for shorter course of KRD will have the same outcome. We will look also at toxicities which were reported at high rate in French study. I don't think their difference is as big as it may appear on the first glance, and I think we need to put this regimen on the radar because it does have, in my judgment, fairly highly significant benefit-risk ratio considering our results, despite some of the concerns from our French colleagues. On the same session, a similar approach with ixazomib RD, again pre and post-transplant course of treatment, showed some of an update from earlier report of that schedule from Dr. Kumar, presented, already published in Lancet, which appear promising. Indirect comparison between this study and KRD studies is unfair and should not be done. I have a sense that they had more patients progressing or failing treatment before the transplant, but overall results look to me very promising, and I again will be looking forward to see how those play out over time. In both studies, and in fact in both approaches in 3 studies, there was post-transplant treatment with triplet for either short course or extended course in our study. That is linked clearly to today's, surprising to many, results of STAMINA trial, our own American CT and BMT trial, in which patients were randomized to either tandem transplant followed by Revlimid or maintenance Revlimid post-transplant, or 4 cycles of RVD followed by Revlimid. So 3 different and popular strategies which we have in the United States were tested, and with many people claiming that one strategy is better than another. What came from this study was, to me, not surprising, but many people have felt it was surprising, that there was no difference in primary endpoint in progression-free survival between 3 different approaches. In other words, at this point, short course of consolidation or even second transplant, as long as all 3 follow extended Revlimid maintenance, are appearing to make no difference. Why it is not surprising to me? I think short course is not long enough, and our results in KRD, which I quoted earlier, are as good as they are, not because of the course of type of therapy or short course of treatment post-transplant, but indeed because of total 14 cycles of KRD post-transplant which we used. And we see that those deep responses are achieved not at the 4 cycles, but ultimately later on in many of our patients. So in short, I think very important updates. We know that we need to explore it further. An evaluation of extended treatment versus Revlimid post-transplant is in progress. It's currently our phase 3 randomized trial, KRD versus R, which internationally is just starting to make its headways into the enrollment.